I will start my presentation. Respected seniors
Can you hear?
and dear colleagues,
Yes, yes.
on behalf
Yes,
of
sir.
International Society of Manual Small Insert Cataract Surgery, I, Dr. Anil Shah, President for Maharashtra chapter, welcome you, all the delegates, speakers, discussion on this wonderful series of webinar that is A to Z of manual small incision cataract surgery.
Today is episode 12, and the topic for today's discussion is hydro procedure, a gentle handshake. The aim of our webinar is to popularize smart SICS. It should be safe, cost effective with minimum learning curve, and it should be useful for community basis. Hydro procedure, a gentle handshake. It is a feel that you are honest and trustworthy. In manual small incision cataract surgery, hydro procedure is a cornerstone technique in modern cataract surgery. In cataract surgery, the art of hydro procedure lies in the balance between gentle maneuver and decisive fluid dynamics, shaping the path towards the clear vision. It is a delicate dance of fluid dynamics where precision meets fluidity to sculpt the path towards the visual clarity. Hydro procedure is a gentle tide that carries us towards the shore of visual restoration. Mastering hydro procedure is a key orchestrating a ballet of fluid dynamic, harmonizing surgical skill with ocular fineness for optimal outcome. And it is the key to the successful cataract surgery. These are the basic images of hydro procedure, hydro dissection and a fluid wave, hydro delineation and golden ring. And for this series of webinar, we have Honorable Chairperson Dr. Prakash Marathe, Dr. Shekhar Paranspe, Dr. Krishna Prasad Kudlu. For today's topic, hydro procedure, a gentle handshake, we have speakers who are expert in their field with the best of their knowledge and experience, Dr. Nitish Dixit, Dr. Arup Chakravarti, and Dr. M.S. Ravindra. And for this wonderful series of webinar, we have discussant who will argue, debate and dialogue, Dr. Neha Deshpande, Dr. Aishwarya, Dr. Pratishtha Somani, and Dr. Helena Philip from Portugal. I am really thankful to all the speakers and discussant for giving their expert opinion, knowledge, and sparing their valuable time and making this webinar a grand success. Thank you. I will hand over to Dr. Ruchita Machwe.
Thank you, sir. I'm Dr. Ruchita Machwe, Managing Committee Member, ISMSICS Maharashtra chapter. I welcome you all for this 12th episode, which is about hydro procedures. At the outset, I would like to hear the pulse of wisdom or the opening remarks from the office bearers of ISMSICS. So, may I request Dr. Amulya Sahu sir to say a few words?
Well, I welcome you all to this wonderful webinar, which is we all are enjoying. And Dr. Marathe, Dr. Anil Shah, all of them have done a good job. And as I say that SICS is the surgery of the future, it is a art that all of us has to master. There is no question of FECO and SICS surgeon. Everyone should become a complete cataract surgeon, and that demarcation should go. So with this, and we are trying our best. And this after this webinar, we will be forming a book, which will be a guideline for everybody in the world. Thank you, everybody.
Thank you, sir. Dr. Jagannath Boramani, sir.
Yeah, good evening, all of you. Without wasting much of time, I should appreciate the work done this year by Dr. Prakash Marathe and Dr. Anil Shah. Successfully, they have conducted 12 webinars in last year, and this is the 12th episode, and dissected the finer aspects of MSICS. So, without wasting much time, I wish all the speakers all the best, and we'll have a wonderful discussion today. Thank you.
I would request Dr. Parikshit Gopte to say a few
I
words.
just echo what Dr. Boramani said. Dr. Anil Shah sir has had, now this is more than a year since this is on, and every month without fail some different aspect of cataract surgery is being covered. And thanks to all the ISMSICS Maharashtra team, Dr. Marathe. And of course, we have three fantastic speakers, senior speakers, Dr. M.S. Ravindran, Dr. Arup Chakravarti, Dr. Dikshit, an excellent panelist. So all of us are looking forward to learning from them.
I request Dr. Prakash Marathe, sir.
Good evening, everyone. I welcome all of you on behalf of Maharashtra chapter of ISMSICS. I think the responsibility handed over to me by Dr. Sahu sir and Dr. Boramani and Dr. Okte. And taking this Maharashtra chapter forward, this year we had our president, Dr. Anil Shah. We are fortunate to have him. And he has designed this course so wonderfully that every time everyone is curious that what will be the next topic. Small topics are well covered. And this is the syllabus. When we were undergraduates and postgraduates, probably that time, SICS was not the topic which was there in the syllabus. And now it is the topic in the syllabus. There are so many books, but these small aspects of SICS are not there. So what our chairman, Dr. Sahu sir, has said, we will definitely come out with the book, maybe soft copy version first and then hard copy version. And the credit goes to Dr. Anil Shah. He has designed this particular course wonderfully. It is almost the syllabus of SICS, and definitely it is getting appreciated everywhere because of this webinar series. Today's speakers are wonderful speakers like Dr. Arup Chakravarti, Dr. M.S. Ravindra, and Dr. Dikshit. They are the bosses in this particular field. And not to forget the mention by Dr. Anil Shah just now, that all the discussions, surprisingly and by chance, are ladies. I must welcome the international discussant here, Dr. Helena, and all other participants for this particular webinar. I wish all the success, all the best to this particular webinar. And I am also thankful to the team Maharashtra chapter SICS that everybody is contributing this year. And this is the great show where participation of each and everyone is there. So thank you so much. Over to you, Dr. Rujita.
Thank you, sir. Let me introduce today's chairpersons. Dr. Prakash Marathe, so Managing Committee member of AIS 2020-23, past President MOS, Trustee and past President Pune Ophthalmological Society, Trustee past President Indian Medical Association Pune, past Senior Vice President IMA Maharashtra, Convener National IMA Headquarters New Delhi, Standing Committee, Prevention of Diabetic Retinopathy Blindness, CWC member, National IMA Headquarters New Delhi, and Chairman Maharashtra Chapter ISMSICS. Welcome, Dr. Prakash Marathe, sir. Our second chairperson is Dr. Anil Shah, sir. He is President ISMSICS Maharashtra Chapter. He is a private practitioner in Nandurbar since 1986. Research award from MOS for snare and large foldable IOL for MSICS. Modified intracystic implant for DCR. He has received MOS Best Research Private Practitioner Award. He has published books and articles on Master Guide of MSICS, Manual FECO, Best Out of West, article for snare in AIS Journal. International presentations, he has got plenty of international presentations, surgical demonstrations, and paper presentations at national level. Our third chairperson today is Dr. Shekhar Paranspe. He is a scientific committee member, ISMSICS Maharashtra chapter. He has got main interest in anterior segment eye surgeries. He's worked relentlessly for eye donation movement in western part of Maharashtra. He's a private ophthalmic practitioner in Sangli, Maharashtra. He's an avid badminton enthusiast and is passionate about the adventure sport of alpine snow skiing. Welcome, sir. I think Dr. Kudlu cannot make today. So now let me introduce the speakers for today. Can you see the slides?
Yes.
Yes, we can.
Yes.
Our first speaker is Dr. Nitish Dixit. He's MBBS MS from HIMS Dehradun, Uttarakhand. He's done long-term fellowship in anterior segment surgery, specorefractive from ASG, Super Specialty Eye Hospital, Mahamurganj, Varanasi, Uttar Pradesh. He's currently working as specorefractive surgeon at ASG Chakshudham Eye Hospital, Lartara, Varanasi. Welcome, sir. Our
Good
second
evening,
speaker
everyone.
is
Thank you for having me on board. Thank you, ma'am.
welcome, sir. Our second speaker is Dr. Arup Chakravarti. He's the director Chakravarti Eye Care Center, Trivandrum. His editor proceedings AIS 2017 to 23. Editorial committee IGO. President Kerala Society of Ophthalmic Surgeons 21-22. ISRS International Council member. Member Scientific Committee AIS. He has got various different achievement awards from international societies. Chief instructor in various prestigious international meetings. Is international elected member of International Intraocular Implant Club, fellow of American College of Surgeons. Is edited 3 books, reviewer of prestigious journals including JCRS, APJO, IGO, etc. Is invited faculty and is invited to perform live surgery demonstrations at various conferences. And he has got more than 76 publications in international, national, and state journals. Welcome, Dr. Arup, sir. Our third speaker is Dr. MS Rabindra. He's done fellowship in VR Sankanathralaya, fellow Cornea Rochester Eye Institute, managing director of Kartik Nethralaya, Bengaluru, Karnataka. Is president of Netra Jyoti Foundation. Is a founder director of Jyoti LASIK Vision Center. Is former honorary medical director of Bangalore West Lions Club Eye Hospital and Cornea Grafting Center. Former president of Karnataka Ophthalmic Society. Former president of Bangalore Ophthalmic Society. And he has received various prestigious awards like IRS Gold Medal Award, Distinguished International Service Award, etc. I welcome all the speakers and now hand over to Dr. Pankaj Shah for introducing our discussions today.
Thank you, Dr. Ruth. I, along with Dr. Ruchita, welcome you all to this wonderful webinar. Here is a wonderful panel of discussions also, as rightly pointed by Marathe sir. We have a woman discussions today. Definitely, it will be more of discussion rather than debate today. First discussion is Dr. Neha Deshpande. She has done her MS Ophthalmology and along with the post-graduation in Ophthalmology, she is Executive MBA in Healthcare, Indian School of Business. She is consulting ophthalmologist at Dr. KG Deshpande Memorial Eye Hospital, Nagpur. She has received Madan Gopal Award for Best Paper Presentation, Dr. Sudha Sudhare Award for Best Video. Welcome, madam. The next discussion is Dr. Aishwarya Saxena, consulting ophthalmologist, Narayan Nethralaya, Bangalore, heads Hospital Infection Control Committee in Narayan Nethralaya, keen interest in surgical training and fellows and PGs training also. Severe international and national publication in various journals. The third discussion is Dr. Pratishta Somani. She is consultant at Gokte Eye Clinic and Manipal Hospital, Pune. She is a glaucoma consultant and has keen interest in SICS and FECO training for residents and trainees. And we have our international guest discussion, Dr. Helena Pryor from Portugal. She has done her MD, Doctor of Medicine from Faculty of University of Lisbon and ophthalmologist by Institute Dr. Gama Pinto and Portugal Medical Association. She practices as consultant ophthalmologist in Department of Ocular Surface and Cornea at Hospital of Igaz Moniz, West Lisbon. Has particular interest in ocular surface and cornea, cataract surgery and ultrasound examination. Welcome all. And now I invite Dr. Nitish Dixit to start his presentation. He will be speaking on hydrodissection, hydrodelineation, aim, techniques, merits and demerits. Welcome, Dr. Dixit, sir.
Thank you so much, sir. Am I audible?
You're audible.
Yes,
I'm sharing my screen.
Yeah, it's visible.
Guys are moving?
Yeah.
Okay. So, good evening, everyone. I should start, sir, no? Should I start?
Yes.
Yes, yes, please start.
So
Yes,
I'll be
please start.
discussing about the hydro steps. So let's begin with the beginner. Firstly, the anatomy. So all we know that lens is a crystalline structure made of 65% of water, 35% of protein. Anatomically, lens is composed of an embryonic part, then a fetal part, infantile part, and adult nucleus with a cortex. And surgically, the lens can be divided into endonucleus, epinucleus, and the cortex. If we talk about the capsule is a thin, transparent basement membrane which is thinnest at posterior pole, measuring around 4 micron. It's of 14 micron at the anterior pole and it's thickest at pre and post equatorial lesion, and zonules are attached somewhat like 2.5 mm anterior to equator and 1 mm posterior to the equator. So little bit about the history. So the idea of hydrodissection was firstly put forward by Dr. Howard Fine in the year 1992. He used a 26 case cannula to perform this procedure to cleave the cortex from the capsule. So if we talk about the aim of this hydro step, the aim is to divide the cataractous lens into three distinct zones: capsule with or without cortex, epinucleus, and nucleus. When it's with nucleus, it's known as hydrodelineation. When capsule with cortex is known as standard hydrodissection, rarely used by anyone. On without cortex, this is known as cortical cleaving hydrodissection or golden hydrodissection, golden procedure of hydrodissection. So what are the tools to perform hydro procedures? One syringe, of course the BSS, and the cannulas. 3 ml or 5 ml syringe can be used. If we talk about the cannulas, there are multiple cannulas. 10 mm cannula is the standard delivery cannula, which we all are having in our OTs. There is 1 mm cannula, especially designed by Dr. Harshul Tak, and there is one more cannula with profile of 2 millimeter. So if we talk about the technique of hydrodissection, the first prerequisite or the prerequisites are the all ports has been already made. Main wounds main wound has been already constructed. Side ports has been constructed. The second thing, the hydro procedure will be done from main wound only. Before we discuss about the technique of hydrodissection, we will having animated video of hydro procedure. I think video is not playing, sir.
So you can minimize this and just play the video separately.
Yeah, sir. I'll do that.
If you have it in a separate folder, you can run that video. Yeah, it's there.
Okay. So the first step is the decompression of anterior chamber. We have to warp out the OVD. Then we will place our hydrocannula somewhere around anterior capsular rim and the equator, and a firm steady wave of fluid is pushed. The fluid wave will go posteriorly, following a path underneath the anterior capsular rim, then proximal equator, then posteriorly, then opposite equator and the opposite anterior capsular rim, then into the AC, and it will egress from the main wound. And this completes the one cycle of hydrodissection. So there are 5 good signs of hydrodissection: good posterior fluid wave, decreased red reflex, nucleus floating or nucleus popping up, shallowing of the AC, and ultimately free nuclear rotation. So there is a short video of this particular thing showing all 5 signs of good hydrodissection. So video credit is to my mentor, Dr. Pratyush Ranjan sir. So firstly, the OVD is worked out, then hydrocanula is placed, a firm steady wave is pushed. We can see a good posterior fluid wave. This wave is moving from here to here, and the fluid is egressing out from the main bone. There is a decrease in red reflex, followed by nucleus popping up, shallowing of the AC. And lastly, the free nuclear rotation. So these are the 5 signs of hydrodissection.
Can you please make it into a slideshow mode? Yeah.
On slideshow mode. So if we talk about the standard hydrodissection, as nobody is using this just for the theory purpose, cannula is placed within the substance of cortex, produces a cleavage plane within the cortex such that the cortex, some part of cortex remain attached to the capsular bag and other part remain attached to the endonucleus. So if we talk about the cortical cleaving hydrodissection versus standard hydrodissection procedure, so IA can be performed more easily with cortical cleaving hydrodissection. It decreases the risk of PCR during irrigation aspiration as there is no cortex attached to the anterior capsular rim, or it's attached very loosely. So during the IA, there is less traction on the zonules. And lastly, if any complication occur during nuclear manipulation, the less anterior segment manipulation in case of any complication with cortical cleaving hydrodissection. So what are the mistakes what we do during the hydrodissection? First is improper placement of cannula, which result in a pseudo posterior wave formation. Second is we are not using enough force or enough fluid. The force and fluid should be very balanced. The fluid requirement is around somewhere 0.5 ml to 1 ml only, and the force is not a very gentle force, not a very hard force. It's a balancing of both. And lastly, the faulty decompression technique. These 3 are the common mistakes which are done by the beginners. Now the hydrodelineation, the aim of this procedure is to separate the nucleus from the epinuclear plate. So no extra tool is required for this, and it's done in the same step of hydrodissection. The hydrocannula is moved in paracentral zone and embedded in substance of the nucleus. The cannula tip is moved forward and backward 2 to 3 times to create a track, and then BSS is pushed slowly and firmly. This will create a golden ring and is ultimately separate the endonucleus from the epinucleus. If we talk about the special situations, I'm not going to the details of these situations. Other stalwarts will be talking about these situations in much detail. If there will be a small capsular axis, there will be, after anterior floating of the nucleus will be blocking everything, resulting in capsular block syndrome or relative capsular block. The fluid will entrap between the posterior part of the nucleus and the posterior capsule, and if there will be more pushing of the fluid, may result in a posterior capsular blowout. If rhexis is very large, there might be tendency of popping up of the nucleus out of the bag. If there is eccentric ECC, then we should try that the fluid egress will be from the intact site only. There might be fluid misdirection syndrome. The fluid misdirection might be from 2 cases. Firstly, if the cannula placement is wrong, is between iris, posterior plane of the iris and the anterior plane of anterior capsular rim, the fluid will migrate transjungularly. Transjungular migration of fluid to the posterior segment will result in the hydration of the vitreous, resulting in the pressure building up in posterior segment and making things very impossible to a anterior segment surgeon to go further in the surgery. And secondly, as I discussed, the very first step is decompression of the AC, as if any extra OVD is there and during the fluid egress, it will block the egress of the fluid from the main wound, and then fluid will migrate from AC to a transjungular pathway to the posterior segment. It's a very rare thing. Lastly, in hypermature mortgagemic cataract, there is no need to do hydrodissection, and posterior polar cataract better avoid hydrodissection and nuclear rotation. Thank you. That's all from my side. Thank you so much.
Testing security issue. Hello.
Am I audible, sir?
Yeah, we can hear you.
Hello, Dr. Pankaj. Is there any issue from your side? Connectivity issue?
Yeah, there is some connectivity issue from my side.
No, but we can hear you now. We can hear you. You can just say and call the next.
I invite Dr. Arup Chakravarti sir for his presentation, complications and management in hydro procedure.
Can you see my slides?
Yes, we can, sir.
Yes, sir. Yes, sir.
So which means I'm audible too.
Yes,
So,
sir.
Yes, sir.
thank you. Thanks a lot, Anil sir and Rujita madam for giving me this opportunity to participate in this very interesting webinar. And the previous speaker has really spoken quite well about the fundamental aspects of the hydro steps. So I will go straight into my topic, which is complications and management in hydro procedures, and nothing financial in the contents of my presentation. So properly done hydrodissection does a lot of things, but what we are basically interested in is nucleus rotation. The nucleus is made mobile, whether you're doing phacoemulsification or SICS, and that is what we are looking for in as an end result of a successfully done hydrodissection. I'll just show you a situation where if proper handling is not done, complication could happen during hydrodissection. So this was a hard cataract. It has a good red reflex, but it is a hard cataract. So my rhexis is about 5 to 5.5 millimeters in size, which is adequate, which is not small. And I have burped the OVD from the incision. So when I started the hydro steps, there was very little opportunity for the pressure buildup within the bag in the anterior chamber. One can use any type of cannula that one is comfortable with. I frequently use the Chang cannula. BSS injection should be performed from the side port in a very controlled manner. Don't go very slowly. It will not serve its purpose. Don't go too fast. The bolus of injection should not be very rapid. And always be on the lookout for a hard eye, intraoperative hard eye. And so that is basically where the capsulorhexis block is happening. And if you don't relieve the pressure, if you don't ballot the nucleus posteriorly and let out the fluid which is collected in the equatorial area, the fluid will collect behind the nucleus and you will have a posterior capsular blowout. I'll show you a couple of videos on that. So this is another situation where, these are advanced cataracts and very elderly patients. They have a very thin, fragile posterior capsule. So one has to be really careful in performing cortical cleaving hydrodissection in these situations. One thing I cannot overemphasize is a burping of the incision. I use a soft shell technique which is a combination of viscoat and nylon. So you have to let out the OVD from inside the eye. As I mentioned earlier, when I showed you the first video, then only perform the hydrodissection. Otherwise, you'll land up in complications. Now, most of the time, hydrodissection goes on pretty well, and the nucleus is rotatable. Sometimes we don't rotate the nucleus, but at times when you demonstrate in any surgical video, we try to rotate the nucleus. But in certain situations, where do you see that you have seen a very good fluid wave, the anterior chamber has become shallow, the nucleus is migrated anteriorly, you have successfully allowed the regurgitation of fluid from the peripheral of the capsular bag, but still the nucleus doesn't rotate. So what do we do in those cases? There are a lot of options. One is the side port rotation. Please remember, don't try not to rotate the nucleus when the anterior chamber is shallow. The AC must be formed with OVD injection, and then this is one of the techniques that could be done. Instead of the main incision, go from the side port using the ISMSICS hook and rotate the nucleus. And next would be a to and fro rocking, as you see here. I'm not using very brutal force to rotate the nucleus. I'm just using just oscillatory movement, rotating the nucleus clockwise and counterclockwise. So this technique is basically useful when you have capsular cortical adhesions. I'll be talking in more details about how to tackle that situation and avoid complication in that scenario a little while from now. Next is, of course, the bimanual rotation. So here, for example, you use two ISMSICS hooks from the side ports. It's basically a proper application of the torque. You don't have to apply a lot of force to rotate the nucleus, and the nucleus rotates pretty well. Now, sometimes, when nothing else works, you can try to rotate the nucleus after sculpting. And if that also doesn't work, then of course we have non-rotational technique for phaco. For example, in those cases where hydrodissection is contraindicated and we can't rotate the nucleus, there are alternative phaco techniques which are available, which one should know to perform safe phacoemulsification. Now, this was a video, I think it is almost 3 decades old. That time I was using a single chip Panasonic camera. So pardon me for the poor quality of the video. So here I did hydrodissection, and all the signs of hydrodissection were seen. Successful hydrodissection is seen, but the nucleus wasn't rotating. So what I did is I just sculpted, made a groove on the center of the nucleus, and then started rotating the nucleus, and it started rotating. So this is one of the things that I had done earlier, but I don't think it is really necessary, but it is good to know. And now this is something which I really don't want to do, hydrodelineation. I feel that this is a technique which creates a thick epinucleus, and in certain situations where the patient is very uncooperative, pupil comes down, you have a post-capsular rent, you have a zonular dialysis, you have a posterior cataract, and the patient has become very uncooperative. Removal of the epinucleus becomes very difficult. But I know some of my friends, who do it particularly for soft cataracts and for posterior polar cataracts. But I would not like to perform hydrodelineation in most of my cataract surgery. Now, these are the potential complications that one has to look out for. Let me go through them one by one. This was a routine case, not a very hard cataract, a standard size capsular excision was done, and I performed a cortical cleaving hydrodissection. The nucleus was balloted successfully. And at one point, if you don't blink, you'll see pupillary snap happen. This is the point. Pupillary snap happened. I missed it during surgery. When it happened. So while I performed phacoemulsification, realized there was a PCN, and so then this is how the eye looked like after the nucleus is removed. There's a large central posterior capsular rent here. So basically, why I got a posterior capsular rent, that is a capsular blowout, I really am not sure of, because rhexis was more than 4 millimeters. It was not a very elderly female patients have a very thin, fragile posterior capsule. Now you need to burp out the incision, the OVD from the incision, the slow and controlled injection. Bag has to be decompressed, and be alert to detect the pupillary snap. If you don't realize the pupillary snap and continue your phaco techniques or nucleus management techniques, in an unaltered with using an unaltered technique, you may end up with a drop nucleus into the posterior segment. So maybe you could think about converting to a non-phaco technique if you see a pupillary snap in a difficult setting. So as I said, sometimes when the rexes become small, like for example, this was a small rexis. I realized that I needed to have larger rexis. So before performing cortical dissection itself, I did a secondary rexis to make a larger rexis, just to ensure that I don't develop a pupillary snap in this case. Now, this was another case which was referred to as a post-vitrectomy eye, total cataract, and I was the surgeon. I was not really sure about the past history. There's a pupillary snap. Again, it will be very clearly seen when I'll show in the slow motion. So here I did not want to take any risk and went ahead and did a small incision cataract surgery. So most probably, when the vitrectomy was performed, there was a posterior capsular touch, and that resulted in the nucleus, the cataract becoming white very rapidly, resulting in the pupillary snap, which you have just demonstrated. So this was one of the situations where, a post-vitrectomy situations where, the nucleus, where the cataract has progressed very rapidly within a couple of days' time. Or if I see a total cataract in a post-vitrectomy eye, I would not perform a cortical cleaving hydrodissection in those cases. Now, this was another case where, yeah. So this was actually not it's a grade 3, grade 4 nucleus sclerotic cataract. Patient had multi-system illness with hypertension, diabetic, cardiac, renal failure. Patient was on dialysis, and patient had received multiple injections elsewhere and came to me for cataract surgery. So cataract surgery is a little bit of a challenge here, but this has become bread and butter for us. People dilate well. Adequately sized capsulorhexis is performed here, and a cortical. Then I started performing a cortical cleaving hydrodissection with a Chang cannula. Please do not blink. At this point, I realized that there was a pupillary snap, but I did intraoperatively. I did not realize. The eye became really hard. Eye became hard. So I thought maybe there was a lot of OVD still left in the anterior chamber. Maybe a lot of fluid that had collected behind in the bag, and it increased the volume of the anterior segment, and the intraocular pressure went up. So I thought I'll just ballot the nucleus, posteriorly, so let out the fluid, which will come out regurgitated from under the rexis margin, and then nothing of the eye becomes soft to a certain extent, but it did not become very soft, and but I could enter the anterior chamber. So at this point, again, I was not really sure whether I had a pupillary snap or not. So I started employing a chop and stop technique here. At this point, the fact that the complication had happened became very clear. The nucleus started getting tilted. I might have converted into a non-phaco technique here at this stage. Patient was actually very restless. He developed pulmonary edema. So I thought that I would be able to remove the lens nucleus as completely as possible. I was able to do it, and towards the end of the surgery, patient was almost sitting up, and I really had to be very careful. So most of the nucleus was removed from the anterior from the front portion of the eye, from the posterior capsular area, but a small chunk of the nucleus you see here goes behind. So here it is a good idea not to chase the nucleus and go behind, and with your phaco handpiece, stabilize the anterior chamber. Do not allow much vitreous to come in. Use triamcinolone acetonide to stain the anterior chamber so the vitreous gets strained. So I did a bilingual vitrectomy in this particular case. Anterior segment toilet was done, and I just closed the incision with a genonylon suture. And then the patient, I left the patient efficacy. So patient went back, had a dialysis done, and came back for the secondary eye surgery. Let me first fast forward it a little bit. Then came back for a secondary eye surgery here. So here you can see, the retina, the posterior segment surgeon using the fragmentome removes the small chunk of nucleus that had dislocated posteriorly, and pupil had come down. So I had to use iris hook. I had a very good rexis, about 5 millimeters of rexis. Diameter size rexis. So a sensor, though my plan was to use a single piece IOL in this case, but looking at the size of the rexis, I mean, the size of the PC rent. Original plan before I started off, first stage plan was to use a single piece lens. Then I ended up using the sensor lens. This is a lovely lens. It is 6 millimeter optic, 13 millimeter haptic diameter, and it is kept in the CLED sulcus. The haptics and the optic is captured posteriorly, buttonhole posteriorly into the capsular bag. So really don't have to change intraocular lens power. Irisoup was removed, and patient had done pretty well. So this is another complication that may happen. Sometimes air bubbles may get into your in your fluid system. When you perform hydrodissection, as you see here. So sometimes if a large air bubble goes in, and if you have a hard nucleus, though I have not had any complication, but I have heard from my peers that that has resulted in a posterior capsular rent. So this is something you should be wary about. Make sure that the hydrodissection, your syringe does not have any air bubble into it. And nucleus prolapse into the anterior chamber. This can happen. This is not desirable in phacoemulsification. This is not desirable in phacoemulsification, but it happens. And most of the time, you are able to push the nucleus back into the bag. Sometimes, if the nucleus is a little soft, it may be difficult, to push it back into the capsular bag, and we may end up, performing a little bit of anterior chamber phaco using a lot of viscoat protection of the corneal endothelium. So here you see the nucleus had prolapsed anteriorly, and then it sort of tilted out, and I was able to push it back. So this usually happens when your axis is quite large size, or you perform a very rapid hydrodissection, and there is rapid fluid dynamics, and the nucleus may prolapse into the anterior chamber, and that is not very desirable when you perform phacoemulsification. And sometimes the hydrodissection can be incomplete. Like, say, for example, now you have to be wary about this kind of situations. Now, this was again almost 25 years old video. So I did a good cortical cleaving hydrodissection. Nucleus wasn't rotating well. So I used a lot of force at one point. It will be very clear that, I was quite, sort of ruthless in trying to rotate the nucleus. And finally, I did manage to have the nucleus turn. Then when I started doing phacoemulsification, then at the end of the nucleus removal, I realized that there was zonular dialysis exactly in the same area. So this is the area of the zonular dialysis. And that was an area of capsular cortical adhesions. So ultimately, the situation was managed well. I injected a capsular tension ring into the capsular bag and implanted the lens that I had planned to implant in this patient's eye. So basically, one has to look out for the capsular cortical adhesion cases. So I mean, most of the time, if the pupil dilates well, you should be able to see it. Sometimes when the pupil doesn't dilate well, or if these adhesions are located in the peripheral areas or subcaps or in the posterior aspect behind the equator, you may not be able to see it. So there is an interesting sign that I've noticed in these cases: lens milk. Now, when you hydrodissect, you find that a lot of suspended lens matter, whitish suspended matter, which comes out from the equatorial area. So these are the cases I know I'm dealing with cases of peripheral capsular cortical adhesions, and I'll be extremely thorough in performing hydrodissection, be very gentle in doing the nucleus rotation in these cases. So here for a demonstration of a similar case where, I had missed, I did not know I was dealing with a patient with capsular cortical adhesion, and because of the lens milk sign, I knew that, it was a capsular cortical adhesion, and I had to be very, very slow. So there are certain guidelines, you try to pick up these cases with the slit lamp itself. And if you haven't done that, then the microscope, when you perform a cortical cleaving hydrodissection, you see the lens milk. So I've already discussed, that, when the meticulous cortical cleaving hydrodissection, no forcible nucleus rotation, and CTR or CTR injector has to be kept ready. Peripheral extension of an incomplete capsular axis tear. Now, this was a case again done a long time back. A lot of annoying reflexes on the nasal side you see here, reflexes coming from maybe the speculum or the drape. And at this point, I hadn't realized then, I had certain difficulty in completing the rexis, and perhaps it was not a continuous curve here. There was an angle into it, acute angle into it. So rexis was completed, and when I performed hydrodissection, at one point I realized that there was a pupillary snap. And I'll be showing it in the slow motion also. So what happens when the pressure builds up in the bag? This was an area of weakness of the. Here it happened. At this juncture, it happened. There was an area of weakness in the rhexis margin which gives way. Now, so then I just tried to demonstrate it. It's not very clearly seen in the video, but I could see it through the ocular. So this is the point where the rhexis margin has run to the periphery. It hadn't become a wraparound tear. I could still do a good, safe phacoemulsification for this patient. But plus remember that when your rhexis is not continuous, when there is an acute angle in the rhexis margin, so you have to be very, very careful when you perform a cortical cleaving hydrodissection. Like this is done again in slow motion. You can see it at this point. Yes, this is the point where the rhexis ran to the periphery at this point in time. So then, so basically, though I haven't had it myself, I have read a JCRS report and I've seen some videos in some of the conferences where the hydrodissection cannula can get separated from the hydrodissection syringe. And so that is something which should never happen. And you have to be very, very careful in ensuring that the system is very tight. So there are certain situations where I would not perform hydrodissection. Wherever I suspect that there is a pre-existing weakness of the posterior capsule or dehiscence of the capsule, or when the nucleus is loose, for example, when it is hypermorganian cataract, white cataract, there's no need for, because the nucleus is not adherent to the capsule. So this was another case. I think I've shown it earlier. So see, for example, the posterior polar cataracts, and this is again a traumatic, post-traumatic cataract. This is again with a traumatic cataract with intraocular glass with double capsular perforation, traumatic cataract. This is after post-operative vitrectomy. So these are the situations when I would not perform a cortical cleaving hydrodissection. I do not do any hydrodelineation, but what I do in these cases is hydro-free dissection. As you see here, just pass the cyclodialysis spatula all around 360 degrees under the anterior capsule till I separate the anterior capsule from the rest of the underlying structures. So friends, in conclusion, I would like to say that hydrodissection is an important step in phaco. It is an unsung hero in the game of phaco. This is what I would like to say, that many a time when you analyze a complication, why it happened, you are able to trace it back, its roots to its incompletely or imperfectly done hydrodissection. So you must be aware of the situations where you should not use hydrodissection. Never ever hydrodissect through the side port. It has always got to be through the main incision. Decompress the anterior chamber, burp out the OVD from the anterior chamber. Decompress the capsular bag whenever the nucleus migrates anteriorly and the intraocular pressure tends to go up, AC becomes shallow. Watch out for pupillary snap. This is one stage where I would not blink. The moment you blink, you run the risk of missing out on the pupillary snap if it were to occur. And some people hydrodelineate soft cataract. I don't use them. And some of the complications that can happen can be prevented if proper guidelines are followed. So thank you very much for your kind attention.
Thank you very much, sir. It was a wonderful presentation and lot many points to take home. Now I invite Dr. M.S. Ravindra sir for his presentation. Posterior subcapsular cataract, posterior polar cataract, would you do hydrodissection or hydrodelineation? Sir, please.
Sir, unmute yourself.
Okay. Can you hear me? I'm unable to share my screen. It shares. Can you permit me to share?
Of course, sir.
Rahul, can you help? Rahul? Yes, sir, it was visible. Your screen was... Share it again once, sir.
I'll do that.
Yes, sir. Yeah.
I can't see my screen.
Yeah, we can see your screen, but this is a Zoom.
And it is of minimal size.
We are seeing your Zoom screen actually. You have to.
You may open the presentation and then share.
Presentation is open here.
Okay.
I'm sorry.
So you can close the presentation, then again go back and then start. And then you can share.
Let me try to do. Is that visible now?
No, sir.
No.
How about now?
Yes,
sir.
Yes. Perfect.
Yes, sir. We can see now, sir.
Sure. Is that full screen or?
Yes, sir. Full screen.
Okay, correct.
Fine. My sincere thanks to the President and Office Bearers of MOS and the entire team in MSICS and today's chairpersons and moderators. I've been lucky to have been given this topic to me, the posterior polar and posterior subcapsular cataracts. And I'll just play some videos and you can ask me to stop. There are 1 dozen videos. I'll just pick them up and continue doing it till you ask me to stop. There are various techniques to handle a case like this where people suspect there could be a pre-existing posterior capsular tear or the posterior capsule under the opacity is very thin and may lead to a tear during the surgery because of pressures inside. So MSICS is the best technique to handle it because of the low pressures that are involved, low fluidics, and you're not going to increase the pressure in the anterior chamber. Basically, imagine the capsular bag is like a balloon. If you push more air into a balloon beyond a threshold, it will break. The same thing, the front of the eye, that is the cornea in front and the posterior capsule behind, act like a balloon. And if you keep increasing the pressure in the anterior chamber, you understand that the posterior capsule and the entire lens, zonula diaphragm, is pushed backwards and the posterior capsule is put on a stretch. So what I would suggest is initially don't overfill the anterior chamber. Just fill the anterior chamber and increase the pressure in such a way that the anterior capsule is put on tightness. So here that you can do it. There's a tunnel floor entry technique. I'm doing a rexis and see, note if you can do if I can section of this, anterior chamber is not very deep. It is just little more than the, it's a closed eye, it's little more than a normal anterior chamber. So I've done the rexis, and then this is my standard technique of the cataract, where I don't take a congenital flap. Sometimes I enlarge the inner areas to create a trapezoid by something. I would always, whatever may be the situation of the cataract in the posterior capsule, subcapsular, always do a hydrodissection with fluid. So this is a must for me. And again, as the previous speakers very elegantly said, then I would have burped out certain amount of it. I would have ensured that the chamber is not deep at all. This is very important. And the fluid can easily circulate within the anterior chamber and in the lens capsule. So you can see I've made this is actually, now we can see what happened was, when I did I was very controlled and the fluid wave separated the cortex and the capsule, went all around. And you can see here a crescent-like light reflects here. That is the separation of the posterior subcapsular cataract. It proved to be a posterior capsule later. And the underlying capsule gets, buried there. And it's surrounded by cortex. You can see it in the further studios. This is a standard hydrodissection cannula that I use. There's nothing, these are very expensive, but actually I take a 27 gauge cannula and straighten it and then bend at 45 degrees for 1 to 2 millimeters. This is too long. My bending is even lesser. Nowadays, I don't go beyond the edge of the anterior capsule. I just insinuate anterior capsule and then inject. That's the best way to get the so that's it. So get a thing. Many times, you can see here, the entire plaque has got separated from the posterior capsule. At this point of time, the entire pressure of the fluid is falling on the capsule behind. So you can see that. And I'm rotating the nucleus to separate all the attachments of the capsule and the cortex, epinucleus, whatever it is possible, gently rotate it into the antechamber. This is entirely against the philosophy of standard cataract surgery teaching in posterior subcapsular cataracts, but it's worked magnificently in my hands. So see that now the chamber there's no increased pressure. The entire eye is in atmospheric pressure. There is no push of the posterior capsule by the pressure in the anterior chamber, as happens when I'm using the phacoemulsification, where the pressures can go up to 30s, 40s, 50s, and 70s. Here it's atmospheric pressure. The capsule, posterior capsule is totally relaxed. I'm continuously injecting visco and aspirating or letting the cortex come. And because I've done a hydrodissection, there is no struggle at all in cortical management. You can see it's beautifully. You can see here the posterior capsule is bare in the center, and the posterior capsule, which is bare in the center, if you increase the pressure, that part will get additional pressure, and the capsule is pushed backwards, and that's the time it tears. So of course, the posterior capsule is only 4 microns and maybe 2 microns in such situation, but that's good enough to take the pressure that you see in the anterior chamber in this. So you can go and do the lens implantation. I'll go to the next video. Can you see that now? Is that visible?
No,
Yes,
no.
sir. Yes, sir.
No.
No, we can
Yes
see
or no?
previous only.
Previous only.
No, this is a different one.
No, no, the video is not changed.
Okay. I'll let you stop sharing and go to the other one. I'm sorry about this. Is that visible now? Is that
Yes,
visible?
screen is visible.
Fine.
Various
So
files, various files are seen, sir.
Huh?
Various
Yes,
files
fine.
are seen, sir. Video is not visible.
Okay.
Now you have to open
Folder is visible.
You have to open the folder, sir.
and then the video will be seen. Yeah.
I've opened it now.
Yeah.
Yeah.
Is that visible, sir?
Not
No.
No.
Oh. I'm sorry, I didn't prepare it. Is the folder visible now? Can you see my pointer?
Yes, we can see the pointer, sir.
Yes, sir.
I'm opening it now. It's playing on my... It's not playing there?
No, it's not playing here, sir.
How about now?
Yes.
Yeah. Seen, sir. Correct.
Right. So there is another case where you can see, the very classical cataract, which is described plaque-like, and there are radiating folds in the posterior capsule, and the lesions which classically, onion skin one. And does it have a PC pre-existing PC tear? That's. I'm careful. I'll just play. I've done a rexis, good rexis there, and then I do a hydrodissection even in these cases, but segmental. I just do a little bit here and there till it comes. This has become hydrodelineation, which I don't like. But what I like is hydrodissection. I don't like the golden ring and all those things. And it's a young patient, so I could easily rotate it clock and anti-clockwise and push the with very little pressure. See that you don't balloon the anterior chamber, so that the PC goes back, and it's carefully taken it out. I don't have side ports at all in my surgery. I have just one main port. And you can see how we can easily remove the cortex without any struggle. And people have described the manual techniques, people have described viscodissection, but I feel hydrodissection, when you can do a viscodissection, why not a hydrodissection? So hydrodissection is much more under your control, and you should have a very good microscope where you have a good retroillumination with stereo, coaxial illumination, and then you can go. You can totally avoid the accident happening of the PC rent. So I think I'll have to keep doing this. Can you see this, sir?
Yes, sir. Yes, sir.
Yeah. There's another case which looks like a PC rent, pre-existing PC rent there. Again, this turns out to be a false PC rent. It's actually in the level of the posterior subcapsular zone, whatever you see initially. I've done a very careful segmental hydrodissection so that, the fluid comes only up to the center on all the directions, 3 or 4 directions. That's a classic hydrodissection cannula I routinely use. Rotate the nucleus. This is a must, in my opinion. It's contraindicated in PSC, but in my opinion, you should not remove the nucleus unless you rotate it. You remove all the attachments that are there between the cortex and the capsule, and carefully remove the nucleus, and you can see that it's an intact posterior capsule. There's no positive pressure at all in the anterior chamber, and that's it. So you have a beautiful thing, and then you go and put a lens there.
The screen is not visible, sir. Now.
Okay.
You'll have to share the screen again.
I'll do that. Is that visible?
Yes, sir. Yes, visible.
Yeah, this is a very dangerous looking eye. I've marked several of them. I think that's a very large posterior polar cataract, and I've done a rexis. I'll just go a little more fast. Enlarge it and do a hydrodissection even in this patient and rotate the nucleus. I could aspirate the cortex because in a young patient. So everything went on well. It looks much cleaner than what it was. There's a lot of debris in the peripheral capsular area. I tried to polish it as much as I could. This is a very interesting case. I put a toric lens in this patient and aligned it to the marks that I had made earlier. That's alignment of the. So because the toric lens, I had to, in every patient, I removed the viscoelastic completely, and Mendes marking done, and I've cleaned up a lot of actions were there in the eye to remove all that. Now you see my hypothesis that if we balloon the capsular bag, what can happen? So I'm going to, at the end of surgery, this is a shallow chamber, I balloon it, and I check the pressure, and it's low. I increase the pressure a little more. Now you see what happens to the posterior capsule. I've increased. See, can you see that? Can you see the tear in the posterior capsule?
Yes, sir. Yes, sir.
Yes, last year.
I'll just replay it a little bit.
Yes, large tear scenes.
So the end of the surgery, I was astonished to see that the posterior capsule tore. When I started ballooning it and forming, it's still low. I just wanted a firm eye, and I chest touch. That's the point with it tore. So this proves that it is the ballooning of the posterior capsule which tears the posterior capsule, not anything else. So I left this patient and I didn't do anything else beyond that because fortunately it occurred after the complete surgery. And then I was very lucky. The patient had wonderful vision and he will never have a posterior capsular opacity in the due course of time, and he is really enjoying the vision.
He will not require yak capsulotomy.
He will never need a yak cap. Let keep. I can stop anytime whenever you want me to stop.
If you have any more interesting videos, we'll have a 1 or 2 days, sir.
Sure, sir. Yes. Some I have difficulty. Is that visible by any chance? The video?
Folder is visible, sir. You'll have to play the video.
That playing part of it is not happening.
Again, it has gone to your folder.
Now you don't see the video.
No.
It's
No,
playing
video. You'll have to play that video first.
I played. It's
In your
playing.
screen.
Yeah, it's playing on my screen.
And then share. Now share it.
It's fine, sir. No issue.
Pardon me, sir.
In the meantime, shall we continue with some discussion?
Yes, sir. Yes, sir.
Please.
Is it playing?
It's playing, but
Okay. We can start the discussion.
Dr. Ravindra, sir, with your permission, can we start the discussion?
please, sir, please,
Yes,
please.
sir. Thank you, sir. Dr. Pankaj.
Can I?
Yes, sir.
May I have 1 or 2 questions here? For hydrodissection, is everyone particular about the gauge of the cannula which you use? Some people use 30 gauge cannula, 27 gauge cannula. Some people use 20 gauge cannula. So,
Sir, even I would like to add that gauge as well as the bend size. Is there any specific
yes,
time when you use shorter length and longer length?
yes. And some people use U-type bent cannula, where at the time of at the place of entry only they do the hydrodissection, sub-incisional type of hydrodissection. What is the specific benefit of such type of cannula, bent 90-degree, 180-degree bent cannula?
Whom are you asking,
Can
sir?
anybody elaborate?
Sir, any speaker can take up the question and highlight, enlighten us about this. Ravindra, sir, please.
Yeah, my thing is playing now. I can explain you on this.
It's in video, visible, sir.
Yeah, this is a 27 gauge cannula. This is what I prefer. The bend is somewhere there. Can you see somewhere at the limbus it was there. I straightened it and then I myself a bend here for about 1 to 2 millimeter. So that was described by my colleague in the previous lecture, and it's bent at 45 degrees. And then idea of doing it is now it goes perpendicular to the edge of the capsular axis or perpendicular equator when you are pushed here. That's the reason why I don't take, if I take a 90-degree bend, it will come somewhere there, which is not sort of a perpendicular to the area where I'm doing hydrodissection. Hydrodissection, the normally, the tip of it, some people pass 1 millimeter, 2 millimeter, some people go up to the equator. The direction of it can be parallel to the iris or parallel to the anterior capsule. Parallel to iris is flat like this. Parallel to the anterior capsule, because the lens is thick in the middle by about 4 millimeter, it zeroes to the equator. So it's a slope which is downwards towards the equator. So this direction is not flat actually. This is at a lower level. The tip of it is at a lower level than bell. You have to bend it down so that the fluid goes there. And then some people push the lens down, some people lift the capsule up. So it's ideally you just enter the space between the capsule and cortex. Don't push it up, push it down or pull it up, and then pass the very little quantity of fluid, and that takes the direction of the space between the capsule and cortex. Then the fluid knows its way where to run. If you tilt it in any other direction, the tip of it can get blocked either with the cortex or can get blocked with the capsule. So if it doesn't happen, then you gently lift it up or go down just by a fraction of a millimeter. Then the fluid starts growing. This is something which everybody has to try it out, and everybody will have a technique of his own or her own, and you'll be able to do it. At this time, this is a very effective method of getting, and you can stop it at any point of time if you are using a 2 ml or 1 ml syringe. I personally prefer a 2 ml syringe, 27 gauge cannula, and bent at 45 degrees. This is a little lesser bent, but because these are manually done, bent at 45 degrees, and I go perpendicular to the circumference of the capsule when I'm going inside. So here again, I'm doing the hydrodissection. You can see I've decided to go across the capsule. Now you can see the plaque is getting separated from the capsule. Here, if you balloon the anterior chamber at this point of time, as I mentioned in the previous thing, that's the time the exposed capsule can get ballooned backwards, and the hydrostatic pressure pushes it and tears it. So in my hypothesis is that there is no pre-existing posterior capsular opacity at posterior capsular tear at all, and every tear that is seen during surgery is iatrogenic. So as I have proved again in the previous 2-3 videos that even those suspiciously very strongly looking pre-existing posterior capsular tear turn out to be absolutely intact capsule when you manage the fluid flow in the anterior chamber in a very adequate manner. See, there's no increased pressure at all. So you can see the edge of the attachment. What do you call a cortico-nuclear attachment? I don't call it as a cortico-capsular attachment. In my opinion, there is no cortico-capsular real attachment. It is all pseudo attachments, because when you increase the pressure in the eye, the whole lens is pushed backwards, and the capsule is abutting against the capsule and offering resistance for rotation. So if you keep the AC in normal depth, there is no cortico-capsular addition. So I've done any number of surgeries of this type. I would again confirm, authoritatively suggest you that there is no cortico-capsular additions. It's all, what you saw is nuclear, and the plaque can get very adherent, and that comes out early, and then it gives rise to various problems that we see. I have many more videos. I think I'll let the discussions go on.
Yeah. Thank you, sir. Thank you very much. I invite Dr. Neha Deshpande, madam, to please give your thoughts and wisdom about today's topic. And would you like to enlighten any more on this?
Actually, I am here to ask a lot of questions because I am still learning. I feel the panel here is so experienced. I am still learning from them. So again, I would like to continue what Dr. Shekhar Paranspe sir was asking. Suppose there is a pupil is say around 6 millimeter where you don't want to dilate the pupil, and your CCC is just below or along the pupillary margin. in this situation, changing the length of the hydrodissection cannula, does that help? Because it becomes very difficult for us to judge the length of the hydrodissection cannula going behind the iris and doing hydrodissection. So I think the speakers can actually enlighten us on that.
Yes,
I
Dr.
think
Dikshit.
your main worry is whether the fluid is going anterior to the capsule. So if you are not sure where exactly your hydrodissection cannula is placed, and you start injecting the fluid anterior to the anterior capsule, it will go transzonularly, and it will give rise to intraoperative hard eye. So that is something which I am told some people have encountered, but it should not happen. When you have to ensure that your anterior, the whatever device cannula that are using for cortical cleaving hydrodissection, I mean, I have used starting from 24 gauge to 28 gauge. At present, I use the Akahoshe cannula, Chance cannula, and the Rycroft cannula, which comes with the Helon or Helon GV. It does fine. Only thing is you just need just appropriate modifications of your surgical technique or handling of the angulation, the way the cannulas are angulated. You have to ensure the tip of the cannula is under the anterior capsule, and you go a little towards the periphery. Not don't inject at the center, because you otherwise it will hold fluid will regurgitate. You'll go closer to the periphery, to the equatorial area, and start the injection. And 5 millimeters or 6 millimeter pupil is good enough, because say our excess is usually 5 millimeters. And if it is less than that, less than 4 millimeters, let's say it's a 4.5, then it is very easy to see the rexis margin. So it is very difficult to miss the rexis margin, and you end up going in front of the anterior capsule.
Is that video visible?
Yes, sir.
Fine. This is what I want, the exact question. I could do a good rexis of about 5 millimeter size, posterior subcapsular cataract, and posterior capsule is going to be thin. See, you can just make out the edge of the rexis, and see, now you got a good hydrodissection. And rotation is the most important thing, is the most controversial thing, because everybody else says no rotation, no hydrodissection, but this goes against all principles. If you understand the anatomy of the whole the cataract, and then the fluidics of the whole procedure, you can see without any difficulty you can remove the even in a small pupil you can remove it. Only thing is you'll have to dilate the pupil good enough to get the proper rexis done. You don't have to stretch the pupil, you don't have to do anything else, and you know the anatomy of the capsular bag and put the lens inside. This is about 4 to 5 millimeter pupil throughout, right from the time you started with it. That's it, maximally dilated pupil.
So I think most of the speakers are saying that it's the length of the hydrodissection cannula is not important. What is important is direction, and you're actually visualizing the place where you are injecting.
Yeah, you're right.
Yes.
And don't disturb the anatomy of the natural lens. Let it be like that, and go gelling with that natural depth. That's the capsular bag, and just go under the capsular bag and inject a very small fluid. Let the fluid find its place to go all along there. Don't manage with instruments, your own instruments, because they may not go parallel to the capsular bag.
Ravindra sir, could you hear, sir?
Namaskara, sir.
Namaste, sir. Sir, I just wanted to ask you how much you extend the corneal wound, sir. It is from the extension keratom I could able to see you extend the corneal wound. How much you extend, sir?
This is a question which is asked by all great surgeons who managed to do their surgery with 1.52 millimeters. So here, to disappoint them, I would say what's most important is how much is the damage we produce to the endothelium. Number one, how much of SIA that we produce. Length of the incision doesn't really matter if you have good control on the SIA. I can do surgery with a 6 millimeter or 5.2 is my standard incision, 5.2. Start with 2.8 and then enlarge to 1 millimeter on either side, because the configuration of the blade is 5.2 millimeters. That's good enough. to remove the cataract without damaging the endothelium even a little bit. Number one. Number two, to maintain the SIA between 0 to 0.4. And if I want more, then I'll enlarge it. If I go on a sleep meridian, Dr. Boramani's various techniques. And it is not purely corneal, it's a sclerolimbocorneal. I start the incision about 1 millimeter behind because it heals very well. Next day, within a week's time, you can't open this because it bonds very well. And it gives a beautiful surface to the front because there is no corneal entry. Corneal entry takes a long time to heal because there are no blood vessels. Because the entry is on the scleral side, it heals, and patients are extremely comfortable without photophobia on day one.
Okay,
So
sir.
my standard incision is 5.2 millimeters. Ultimately, it's a single tunnel. I don't have side ports.
Yes, sir. Thank you.
Ravindra. See, he was asking you how much you extend inside.
Please. Let's have a discussion on hydrodissection and delineation, sir, please.
Tell me.
The topic is today on hydrodissection and delineation. We will have a discussion on this topic first, sir.
Okay.
Dr. Helena, can we have your thoughts and wisdom on this topic, please? And I have also come to know that you are Vice President of Pan American Ophthalmology 2025 till 2025 and webinar coordinator for the same. Congratulations for the same.
I'm not sure of this credit. So thanks if that is true, but then only Amul Sahu and Boramani have to comment on that. I'm not aware. They are invited. They've invited me, and I'll be participating in that. I look forward to that. But Vice President, I'm not sure.
So she's the Vice President for 3 years.
Helena.
Yeah.
Yes, Vice President of Pan American Association of Ophthalmology.
Please, madam, can you...
Helena, ma'am, unmute yourself.
Unmute yourself, please.
Yeah.
Thank you so much. So it's a difficult task to comment such beautiful iconographic documentation that we have been offered by the 3 presentations and the speakers, and so much their presentations can translate what they so much they know about their experience on cataract surgery, and especially focusing on hydrodelineation and hydrodissection, and bringing up challenging cases that we can encounter in our practice, and sharing that experience. And those pearls, as we have seen, are of utmost richness, and made this webinar and this encounter a wonderful learning moment. And I would also like to emphasize the importance of sharing videos and bringing this practice into something that we encounter, that we can say that in this case, it's not only the image, but also the motion of the images and the videos that can speak by themselves so much than the articles. Nevertheless, I would like to pay my respect and admiration for this group, for the willingness to advance scholarship in the work that this incredible society is doing. So not only the practice, but also combining this practice with scholarship, and then imparting this rich experience. So I would say that we can find these cases wherever we are in the world. We can find them in more remote places, also in Western, Eastern world. And knowing about this experience is very rich for ourselves. Something I would like to ask of you is how you impart this type of experience with residents, with fellows. And I could also feel from the presentations and the speakers and the faculty, I would say, how much they have learned by themselves from their experience and from their mentors as well. that they had found a most distinct way of approaching these challenging cases. Nevertheless, also underlining the case that no cataract surgery is equal to another. And sometimes we are expecting to be something uneventful and turns out to be a little bit more challenging, and vice versa. But I would like also that you please, how you consider of translating this very rich experience with your residents, with your fellows, to support this amazing school that you are doing right now in this within the society. And my words are of gratitude, admiration, respect for being here with you, learning from you, always learning. We are, I think, a little bit biased. Every ophthalmic surgeon always likes to see a little bit more of a video, a bit more of some discussion, but videos, it's kind of, just being with friends and talking, but the videos are for sure something that enlightens and encourages further. And speaking about these experiences is very, very rich. So these would be my words of gratitude and admiration and thankfulness and encouragement to move forward with this society that has also something that is very, I would say, very magnetizing. That is building the chapters as nodes or anchors, just spread across the world. And we can see this beautiful network linking all these chapters and how this society envisions to learn ophthalmology, especially cataract, as we are speaking right now, but how the society, by their leaders, of course, by their members, of course, envision how it is to learn ophthalmology across the world and how the world has become so global and short in certain way, and you make it shorter by envisioning that way and doing this fantastic network of chapters, which are nodes, which are anchors, which are people linked together. Thank you.
Thank you.
Thank you very much. Dr. Aishwarya, can you have your words of thought, wisdoms on today's topic? Or any specific?
Thank you so much. I would just like to ask both Dr. Arup and Dr. M.S. Ravindra sir have been my teachers. So there is a question which I had that would you like to comment on the post anti-VEGF injection eyes and what methods of hydro procedures would you like to employ, especially for beginning doctors who are starting and who encounter these in their regular practices? Your comments, please.
I think, Dr. Aishwarya, if I have to take it, there was an epidemic of, such cataracts, traumatic cataracts associated with anti-VEGF injections when, everybody started performing it, general ophthalmologists. So we used to do at least 3 or 4 cases per month. So those cases, as I told you, I would be doing phaco. I would rather wait for some time for the posterior capsular tear margin to get fibrosed. I won't go in immediately. And once it is little fibrous, then I go for phacoemulsification using a technique which does not depend upon cortical cleaving hydrodissection. And we have actually gone through that stage almost 5 or 6 years back. Now the numbers of such cases have come down, where we have the posterior capsule that is the needle that is grazed against the posterior capsule. That has come down drastically, but it was happening quite frequently, quite regularly 5 or 6 years earlier, maybe a little 6, 7 years earlier.
Thank you, sir.
And
there's another question which I would like to ask.
A good inventory of lenses, those cases, because in case you are not able to maintain the integrity of you have a large PC rent and you're not able to do posterior capsular axis, you need to have a good inventory so that in the same sitting itself we can use a 3-piece hydrophobic acrylic lens in the sulcus with an optic capture.
And I would like to ask this specifically to Ravindra sir. Whenever we are talking about the hydro initiation, are we going to use the word tenting of the capsule? And would you like to recommend it to the students? Yes or no? Before you begin
if you follow my technique of just entering the space between the capsule and the cortex, you can move it, tangentially, but then there's no need for tent. But if it does not initiate the flow of fluid, then you can tent it up, create a funnel there where fluid can go through it. But initially, I would like to not to disturb the anatomy of the lens. Let it be beautifully like what it was created by God, and then you don't meddle with anatomy. Just go and let the fluid do the job. If it doesn't work, tenting is fine, but tenting should not be used right in first go, in my opinion. Because
And Arup
there's so
sir,
many
there is,
techniques.
and Arup sir, I would like to ask this, that if cortical cataract is present, let's say in only 1 or 2 quadrants, not more than that, then would you like to do the hydro procedure just opposite to that instead of?
Can you repeat the question? I mean, your voice was breaking.
So if you have a cortical cataract present on only 1 or 2 or 3 quadrants, would you like to do hydro procedures just opposite to that area of cortical cataract and then proceed with the surgery, or would you do it in the same quadrant if it is convenient to you?
I mean, it's an interesting question. If it is just a cortical cataract which is located at a deeper plane, I would not be really concerned about it. But there are certain situations where you have adhesions between the cortex and the capsule. So initially they are cortical capsular adhesions, and if these patients don't come in for surgery immediately, they're going to develop a fibrotic plaque. That can be easily dissected. I mean, you need to learn how to do it, but it can be dissected from the anterior capsule. So you go with my cyclodialysis spatula, and then you just scrape the undersurface. Try to mechanically lyse those adhesions. In spite of having done a good hydrodissection, I'd still like to mechanically lyse those areas and then go ahead with my routine phaco technique. And Howard Fine, coming back to your previous question, Howard Fine, when he taught about cortical cleaving hydrodissection, he did mention about tenting the anterior capsule with hydrodissection cannula. So I would agree with Dr. Ravindra ki, I mean, it may not, I mean, there's nothing hard and fast. You have to, this is a dictum, you cannot go against it, nothing like that. I mean, as a surgeon grows in experience, he finds out, a good, a balance between the technique that he's using, with the instruments that he's using, and the case that he's operating upon. So it is very hard to say that you should not do this or should not do that or must do this. It comes through experience of maybe 100, 150 cases, maybe a little more than that. So regarding the length of the hydrodissection cannula, the shortest length that I've used is the Chang hydrodissection cannula. It is a U-shaped cannula. So, it has a larger bore. I think it is about 24 or 25 gauge. So it comes with a sort of a lot of fluid that is, injected into the eye, into the, subcapsular area with a lot of force, a lot of hydraulic force. On the other hand, if you take the Rycroft cannula, or the cannulas, flat cannulas available in the market, those are 27 gauge cannulas. So with that, you have to go little deep, cross the midline, go closer to the equator of the capsular fornix and start injecting there. Because if you inject at a proximal level, the fluid will sort of come back. It will not go into the deeper area, and then you will end up loosening up a lot of cortical stuff and all that. I'm talking about from a beginner's point of view. After some cases, when you're done, when you're mature and you ripen as a surgeon, of course, you can manage most of the situations. But for a beginner, I think you need to follow certain rules which makes life a little easier, a little more predictable. Did I answer your second question?
Yes, sir.
Can I answer? Dr. Paranjape, yes.
Yeah. I think we are almost coming to a conclusion of the meeting. But I have 2-3 queries and one challenge which I want to throw for the present ISMSICS body. Dr. Boramani, Dr. Amulya, this one challenge we all must take. Now, this is year 2024. we will be celebrating on 29th November 2024 Diamond Jubilee of the first intraocular lens implant that was done way back in 1949 by Sir Harold Ridley. So we must celebrate this day. We must celebrate Diamond Jubilee of this event in a big way. And this is really a challenge which we must take. And now the 2 or 3 queries which I have got. During this hydro procedure, by oversight, have we omitted 3-4 types of hydro procedures? One is stromal hydration at the conclusion of the surgery. 1. 2. Sometimes leftover cortical cells, we can just blow it off with the jet of saline. This is also a hydro procedure. 3. Bringing out the cortical bowl from the AC or from behind the AC also by jet of saline, and then we bring it out of the wound also. This is also a hydro procedure. And the 4th point which I want to say is, you may laugh at it, but instilling the irrigating fluid on the cornea, this is also a hydro procedure. And that is a job that is done by your assistant. So you have to be specifically train your assistant how to instill the drops, especially in when we are doing at a topical and when the anesthesia is wearing off. When we instill the drops by jet, the patient becomes very conscious and then he forcibly squeezes the eye. That is at the conclusion of the surgery. So at such time, we have specifically tell your assistant to be very gentle while instilling the drops. So these are the 4 points. I really don't know whether by choice they were omitted or by oversight they were omitted, but they are all important hydro procedures. That's what only thing which I wanted to put forth.
Even Blumenthal's mini nucleus is also hydro procedure.
Which one?
Expressing out the nucleus in Blumenthal technique is also hydro procedure.
Yes.
Sir, these steps were not omitted. They were not omitted. They were kept for you, for your expert opinion, your expert comment.
Dr. Pratishtha Somani would like to
These
hear
are
from
extra additionals.
Yeah.
Dr. Pratishtha.
Good evening, sir. I'm very thankful to everyone from ISIS to make me part that they made me part of this discussion. I learned a lot from this. I have few questions to Arup sir. I have learned a lot from his discussion and the way he explained everything with the videos. But I wanted to understand more about a hydro dissection, this hydro-free dissection which he mentioned. One for the cortical adhesion, in case of cortical adhesion. In what other cases we can do that? And is it safe to do to be done by the beginners?
Yeah, it is absolutely safe. So, this is a technique which is not. I was not the first one to do it. I had read in the early 90s when I was doing my fellowship in a book by Howard Fine or Richard Kratz, I don't remember, where he had described this technique. So then I thought, why not utilize this technique for situations where you need to separate the anterior capsule from the underlying structure. So that means in the posterior polar cataract, using a cyclodialysis spatula from the 2 side ports and then the main incisions. And in those cases, which Dr. Aishwarya had just mentioned, where you have a fibrotic plaque, connecting the anterior capsule to the underlying nucleus, and then the water will not break those adhesions. By hydrofluid, the hydraulic pressure will never, break those adhesions. So you need to pass a cyclodialysis spatula under this to just mechanically lyse it. It happens in some situations where you're able to, easily, separate those adhesions. So it is not difficult at all. Just use a cyclodialysis spatula from the side ports to have the anterior chamber well formed with any space occupy, any OVD, the cohesive OVD, that's good enough. It is easy.
So one more thing, you mentioned that we should not do hydro dissection or hydro procedure from side port. But initially, when we learned SICS, it was very difficult to manually clean using IA, clean the subincisional cortex. So we were sometimes taught to do hydro dissection in the subincisional area from side port to loosen up the cortex there also. So
are you talking about cortex aspiration? The cleaning up the capsular bag after the nucleus has been removed?
No, sir, hydro dissection Initially we used to do from main port, and at the end we'll do from the side port in the subincisional area to free the cortical fibers in the subincisional area, so that become cleaning them in IA during IA becomes easier at the end.
No, I think it is not a very good idea because it is quite logical to think that way also, because your side port is not a big incision. At the most, it is a point about, let's say, 1 millimeters in size. So if you start injecting fluid, and there is no regurgitation of fluid that is happening. So it's like a balloon. The whole eye starts ballooning up. On the other hand, when you go from the main incision, you have to separate the clear corneal incision, which has length, and so that fluid comes out automatically from the anterior chamber. If it is from the side port, it is not going to come out, and you are more likely to end up with a posterior capsular blowout. I don't think it is really good idea. However, if your side port is a large side port, many of these SICS cases when I have done in the past, using a simple cannula from the side port to remove, the subincisional cortex. So then those side ports are a little larger in size. So maybe that is not what I meant when I said that, your hydrodissection should not be performed through, the standard side ports, which are about maybe 0.5 to or 1 millimeter in size. So it is better to follow the grammar, follow the rule book, because if you have a complication, then you know that you have violated certain surgical principles, and you'll be regretful about what has happened.
Yes, sir. So I wanted to understand about a recent study also, in which we have read about it, phaco sleeve assisted hydrodissection, in which again they block the main port with the phaco sleeve and then do the dissection using the side port. It was a study.
I'm not sure about. I don't think I've heard about what technique is this. This is
The phaco sleeve,
hydrodissection.
phaco sleeve assisted hydrodissection, in which you block the main incision with the phaco probe sleeve and then do it. It was some recent.
Has it come out in any peer review literature, or just in the University of
In
YouTube?
IWAS, I think. Studied.
I have not really heard about it. If you can pass on some more information on this thing, why do you plug the incision? Why do you create the incision? If you're going to hydrodissect from the side port, why do you create an incision and then plug it with a phaco sleeve? So I'm not able to get the full story. What is the why it is the sequence is followed?
I'll look up the whole thing and then share.
Dr.
I
Rujita?
think this is the time to conclude the session, since it's around 10:45 now. So before I invite the chairpersons for the concluding remarks, since Dr. Kudlu is with us, I'll just give a brief introduction. Dr. Krishna Prasad Kudlu is a medical director, Prasad Netralaya Group of Super Specialty Eye Hospitals. He is trustee, Netrajyoti Charitable Trust, president, Karnataka Ophthalmic Society. He is editor, proceedings, All India Ophthalmology Society, former chairman, Vision Committee, Government of Karnataka. He is honored with gold medal in international conferences, organizing secretary, COSCON, organizing chairman, COSCON, state's highest civilian award, Karnataka Rajyotsava Award. He has received in 2019. So welcome, Dr. Kudlu. And
Thank
now,
you. I'm so sorry that I joined half an hour late due to unavoidable reason.
it's our honor that you joined.
Oh,
I
good evening.
will ask the chairpersons to give their concluding remarks. Dr. Krishna Prasad Kudlu, sir.
Yeah, I was just part of Arup sir's presentation and Ravindra sir's presentation. But only thing is what I just wanted to tell. What an amazing technique. I think when Sahu sir started around 2 SICS, I still remember that live surgery. And then later on, the SICS, what SIA, which has been described by Dr. Bormani, which is something amazing, what Dr. Ravindra sir was connecting with that 5.2 incision. What he wants to say that even in spite of 5.2 incision, still it is almost the astigmatism is almost nil. And apart from that, I could be able to learn some very good hydrodissection techniques. Still, because I'm basically SICS surgeon, now I might be doing a lot of phacos, but my thesis way back almost 1994. That time nobody was done a SICS thesis. I have done the SICS thesis because that time people used to think what kind of technique this fellow doing and all. Because I used to take a lot of materials from Arvind and used to learn, but I could able to learn so many things. I think always I want to be part of this technique more, this webinars more and more. Thank you.
Thank you, sir. Dr. Prakash Marathe, sir.
I think it was the fantastic webinar today. Basics were covered by Dr. Dikshit, and then important tips were given by Dr. Arup with beautiful videos. And not to forget Dr. Ravindra sir's contribution of his own technique of not having that scleral incision directly the corneal entry. Few of the things which are not there in routine SICS, but they are best in his hands. And the handling of osteocapsular opacities and that PC tear, everything was fantastic. I think SICS and phaco, if we compare, this hydro procedure is very important in both these procedures. And about phaco, you have got so many parameters to handle. But in SICS, I think it is the instruments and bottle height and your own technique. One more important thing of comparison of phaco and SICS, that you have got limited space at the time of phaco for handling your cortex and your nucleus. It is behind the pupil, that is in the back. But in SICS, I think you have got little more liberty to handle that cortex and nucleus, I think outside the bag also. And with that liberty, SICS has got little less learning curve, I should say, as compared to phaco. And the results are best in the hands of experts like Dr. Sahu, Dr. Boramani, Dr. Ravindra, Dr. Arup. And we have experienced all these procedures step by step in this particular webinar series. And today, I think it was hydro procedures wonderfully covered by each and everyone. Even the discussants, they have shared their knowledge. Very important questions and answers were aptly given by the presenters. And it was a fantastic webinar, I must say. Fortunate to participate in this.
Thank you, sir. Dr. Shekhar Praspe, sir.
Yeah. In our everybody's mind, once Mr. Dr. Charles Kelman is hidden. So we always think of some innovation. What we have today done, talked about is a hydro dissection. But shouldn't we move forward? There is now a knife available, which is called as a hydro knife, a water jet knife. So if we can use or develop such knife in our cataract surgery practice, then probably by jet of water also we can take the incision, we can do the capsular excision, and we can remove the nucleus also. So the time has come for us to move forward from phaco as well as from SICS, and I feel hydro knife is one way of doing this. Thank you.
Thank you, sir. Dr. Anil Shah.
Thank you very much. Just I wanted to conclude that only one important thing is that the amount of fluid coming out of the eye should be more than the amount of fluid going inside the eye. That is the key success of hydro procedure. If the fluid is going more and the fluid coming out is less, then chances of complications are more. So in SICS, we get least complications because the incision size is more and the amount of fluid coming out is more. So we don't get much complication in SICS, but in phaco, we get more complications in hydro procedure. Another point Dr. Shekhar Paranspe has said about hydro procedure is one important thing is remaining is hydro implantation, which we are also doing as a hydro procedure, which I wanted to highlight. And another important thing is I wanted to give complimentary snares to all the speakers and delegates, and those who want, they can send their address to me. I will send you 5 snares each of them. Thank you very much.
So what about the moderators?
Yes, all, everyone.
Thank you, sir.
Those who send me their address detail, I will send you immediately. No problem.
Thank you, sir.
Thank you.
Now I request my co-moderator, Dr. Pankaj Shah, to propose a vote of thanks.
Thank you.
See Dr. Pankaj Shah.
I thank all the esteemed speakers for sharing their thoughts and enlightening us. Dr. MS Ravindra sir, Dr. Arup Chakravarti sir, Dr. Dikshit sir, and all the esteemed panelists for giving their thoughts and comments on the topic. Equally, the chairpersons and office bearers of ISMSICS Maharashtra chapter and all the wonderful audience who were there till late 11 p.m. We are there for this webinar. I thank all of you and the host Rahul and Intro team for such wonderful arrangements of the webinar. Thank you all of you for being there.
Thank you.
Good night.
Thank you, sir. Thank you very much, sir.
Thank you, everyone.
Very
Thank
nice.
you.
Wonderful. Wonderful.
Thank you and good night.
Good night. Good night. Good night.
Yes, sir. Thank you very much. Nice, wonderful webinar, sir.
सर पिछला भी स्नेहर बाकी है सर अभी तक